I've been asked to talk about managing hypoxia and assessing patients with respiratory problems. So I'm going to give you a little bit of background, and I'm going to be referring particularly to the current BTS guidelines on air travel for passengers with lung disease. And I'm also going to refer to a primary care summary, which we published a bit more recently. So I'm going to talk about the initial assessment, what clinicians are looking for, what primary care physicians should be looking for, and specialists. I'll talk briefly about some absolute contraindications to air travel, and you've heard about one of them already from Matthew, although he came back to tell the tale. I will talk about the Hypoxic challenge test and some of its limitations. I'll talk a little bit about the logistics of travel with oxygen and a little bit about patient information, although you've already heard a lot about patient information and you've got some very good guidance. So the main challenge of air travel for passengers with respiratory disease is the hypobaric environment. So it's the fall in pressure. It's not a reduction in the percentage of oxygen, but it's the fall in pressure that leads to an apparent reduction in the amount of oxygen. Now, we did, as some of you will know, a prospective study of flight outcomes in over 600 passengers with respiratory disease, which we published in the European Respiratory Journal in 2007, and we found that actually commercial air travel did appear to be safe. Those patients, of course, had been carefully assessed by respiratory specialists beforehand. This was a hospital-based study, and the mortality was just 1%. Generally, people do well if they've been assessed carefully. I should also mention that the BTS recommendations, they apply only to commercial flights. This includes scheduled repatriation with a medical or a nursing escort, but they exclude emergency aeromedical evacuations, so I won't be talking about that situation. And the BTS recommendations were first put together in 2002, and they were the first comprehensive recommendations worldwide to assess a wide variety of respiratory conditions. There was some guidance before that for patients with asthma and patients with COPD, but there was nothing for other conditions. And then we updated those in 2004 via a web update, and then much more fully in 2011. But anybody who has a particular interest in this subject, if they want to read around the background, they should go back to the 2002 document, which is still on the BTS website, because that retains a lot of additional background information, which we had to leave out in the updates because it was becoming too lengthy. And then, as I said, in 2013, we published a summary for primary care practitioners to give them some advice. So obviously, in terms of the background, we know that air travel is still very popular. Many of you will have travelled to this conference by air. In the first quarter of 2015, UK airports alone handled over 50 million passengers. And in that year, nearly 3.5 billion people were transported by air worldwide. And it's not getting any less popular. And of course, Western populations are getting older. So statistically, it is just more likely that passengers will have at least one long-term medical condition. But they expect to be able to fly safely without any incident, because air travel now in many parts of the Western world is considered commonplace. And even 40 years ago, it was considered that around 5% of commercial air passengers, had one or more long-term conditions. And that hasn't been reviewed to my knowledge, but it's likely to have risen. So healthcare professionals really do need to be able to address questions from patients and carers about air travel, and they need to be able to anticipate and help prevent potential complications. And the impact of air travel on health was recognised and highlighted in this BMA report as long ago as 2004. And if you're interested, you should have a look at that. And it's not just about respiratory disease, but it addresses a wide variety of common medical scenarios. So in terms of the hypobaric environment, excepting emergencies, commercial aircraft are pressurised to 8,000 feet or just over 2,400 metres. And the partial pressure of oxygen at that pressure equates to just over 15%. Now, we know that even in healthy passengers, the PO2 will fall to between 8 and 10 kilopascals when they're seated. And it obviously may fall further if they're exercising, if they're walking up and down the cabin, as they're often encouraged to do on long-haul flights, or if they're sleeping. And the usual physiological response is mild to moderate hyperventilation, that is limited by a fall in PCO2, and a moderate tachycardia. So it seems very reasonable to assume that exposure to cabin altitude is going to worsen pre-existing hypoxemia, so patients with respiratory disease who are not healthy. And we should obviously be giving particular consideration to those who already require oxygen at sea level. Now, there is expansion, as we've already heard, of air within cavities, which can present problems, particularly if you have a closed pneumothorax or a non-communicating bulla. And that figure that I've quoted there of 38% is the figure for saturated air, because you have to allow for expansion of water vapour as well as air. And, of course, the other challenge is immobility from overcrowding, particularly in economy. Now, that is not unique to air travel. It's also the case on a long coach journey or train. But there is obviously a greater risk of venous thromboembolism and exposure to respiratory infections, and we've touched on that already. So the most important initial assessment for your patient is the history. We know that spirometry and saturations provide very valuable information in assessing clinical severity, but neither of them have been shown to reliably predict hypoxemia or clinical outcomes of air travel in passengers with lung disease. And so our latest recommendations are very pragmatic, and they include particular reference to the history. And people should be asking about the passenger's previous air travel experience. Where have they flown to? How recently? Did they have any problems? Where are they flying to? That's very important. We've heard about high-altitude destinations. Is their condition stable? Have they recently had an exacerbation? Have they been in hospital? And can they walk? How far can they walk? We've heard about the distance from the terminals to the check-in desks. The patient's condition should usually be stable before they travel, and it's a great opportunity for physicians and patients to optimise their medical care before they travel, and Matthew alluded to this as well, so particularly bronchodilator therapy, their inhaler technique, that should all be checked before they travel. So which patients need further assessment? So the BTS guidelines at the moment suggest that a specialist respiratory physician should see patients if they've had problems previously during air travel, if they have severe COPD or poorly controlled asthma, bullous lung disease for the reasons I've mentioned, severe restrictive lung disease, that could be diffuse lung disease, it could be muscular disease, which our audience have raised. Patients with cystic fibrosis may have particular requirements. Patients who've been diagnosed with TB, and I'll talk a bit more about that later. Patients who've recently had a pneumothorax or acute illness, or who are at increased risk of venous thromboembolism. And also patients with comorbidity, which will be worsened by hypoxemia, particularly cerebrovascular or cardiac disease or pulmonary hypertension. I'll talk a bit about that in a moment. And those who have pre-existing requirements for oxygen, CPAP, or ventilation at sea level. Now, patients with cardiac comorbidity are important. In our UK flight outcome study, we had 2 patients who died while they were away during that 2-week window, and they both died of acute cardiac events. And obviously, in patients with COPD who've smoked, cardiac comorbidity is very common. So those patients should be discussed, I believe, with cardiology, as should patients with pulmonary hypertension. But the British Cardiac Society has published guidance for passengers with cardiovascular disease, and it's a very exhaustive and comprehensive document, and I'd encourage you to look at that, and that is the reference there. So if you have patients with cardiovascular comorbidity, you should think about that as well, and not just the lung disease. But just to summarise some of the common conditions, patients with acute heart failure, once they're managed and stabilised, should normally be able to fly within 6 weeks. And if they're stable in functional class 3 or 4, they should have supplemental oxygen. And I've just summarised the NYHA functional classes for you there. The same for patients with pulmonary hypertension. If they're in functional class 1 or 2 with no limitation of physical activity or slight limitation only, they should be able to fly without oxygen. But if they're in class 3 or 4, they should have oxygen. But I would suggest those patients should be discussed with the specialist who usually manages them. I'm just going to mention briefly about children and infants. So BTS recommendations suggest that infants born at term should wait for a week before flying to make sure that they're healthy. And there's further advice for professionals assessing infants and children with lung disease in the latest recommendations. So there are very few contraindications to air travel, absolute contraindications, but they are important. So infectious TB is an absolute no-no, obviously. Pneumothorax with a persistent air leak. Usually we recommend that patients wait at least 7 days after the lung has re-expanded on chest X-ray, once the chest drain has been removed or any other treatment has been performed. And the current BTS guidelines suggest 14 days if it was traumatic. There are some later data suggesting that that may be too conservative. But there were a few incidents of patients having problems when they flew within that 14-day window. So those are the current guidelines. Major hemoptysis, I think for other obvious reasons, not least for other passengers on the flight. And those usually who already need LTOT or long-term oxygen therapy at a rate exceeding 4 litres per minute at sea level. And my colleagues in the airlines may correct me, but most commercial airlines don't supply oxygen at flow rates above 8 litres. And our usual advice is that you double the flow rate. So that is the reason for that. I think there are some exceptions. We may hear more about that later. So what about the hypoxic challenge test? This is performed in a specialist lung function unit after the patient has been assessed by a respiratory specialist. And for the reasons I've outlined, it's usually only in complex patients with more severe disease. And the aim of that test is purely to decide whether the patient needs oxygen to fly. And when we wrote the BTS recommendations, there was not sufficient evidence to determine its precise role in patient assessment. So the current guidance leaves that to the respiratory specialist's discretion. And patients who are already on LTOT at sea level shouldn't need hypoxic challenge test. Just recommend that they double the flow rate of their oxygen at cruising altitude. So what about the logistics? In whatever way the lab decides, the patients will breathe the equivalent of an FiO2 of 15% for just 20 minutes. Now, we all know that most flights exceed 20 minutes, and most hypoxic challenge tests do not reproduce the reduced relative humidity, which has been talked about, which is very important, or the need to walk to the restroom or up and down the cabin during the flight. So the hypoxic challenge is an imperfect assessment. In terms of the outcome, the generally accepted criteria for recommending oxygen are if the PO2 falls below 6.6 kilopascals or the saturations fall below 85%. We had a query from one of our audience earlier about what might happen if you didn't fulfill those criteria but you thought the patient was distressed. My own view in that situation would be you would probably advise the patient to have oxygen available. But of course that may cause problems if they're travelling with an airline who charge. So there are all sorts of considerations. We usually only advise supplemental oxygen at cruising altitude. And if you have a very highly complex patient, say somebody with a very large bulla or who has lots of problems on short flights, if you're still worried, you can refer the patient for hypobaric chamber testing. And this is obviously the gold standard, but not usually available. But this shows you a hypobaric chamber at RAF Henlow. So there are facilities where you can do this, and this is obviously done for military aircrew. But this, of course, does reproduce the hypobaric environment and is therefore much more accurate because it's not making any assumptions about 15% oxygen. So what are the implications of the hypoxic challenge test? Well, as I said, it's used to decide whether a passenger needs in-flight oxygen or whether the specialist thinks it would be a good idea for them to have it. I would reiterate, it's not a fitness to fly test. We repeatedly get patients saying, I'd like my fit to fly test. It's not saying that patients are safe to fly. It's saying if you fly, we recommend that you have in-flight oxygen. So even with in-flight oxygen or ventilator support, we cannot guarantee that air travel will be safe. 2 of the 5 patients who died within 4 weeks of air travel in the UK flight outcome study had travelled with in-flight oxygen, and they'd used it. So that was probably just a marker of the severity of their disease. It cannot guarantee safety. And I would encourage physicians to record the discussion in the medical notes. We always say that the respiratory specialist or the paediatrician is the central referral point for considering safety to fly. But patients ultimately do take responsibility for travelling. And I always do tell my patients that the airline can refuse carriage if the passenger safety is in doubt. So I had a patient recently. She wanted to fly from the UK to India. She wanted to visit her family. Her daughter was insistent that she was going to go with her and they were going to fly. She not only had a very severe pulmonary fibrosis, but she also had pulmonary hypertension. And I did not consider she was safe to fly, even with oxygen, and neither did the pulmonary hypertension specialist. But the family insisted on asking me to complete a medical form for the airline. There is a little box you have to tick, and it says, what is the risk, or what is the outcome? The forms vary, as I'll show you. I put that I thought this was a high-risk patient. She came back to see me 6 weeks later in clinic. The airline had refused to take her because I'd written that. So there is there's a second opinion, actually, on the respiratory specialist recommendations. So if you're really concerned about a patient, I'd encourage you to say, you've provided and done everything you can, but you still think this flight is high risk. So somebody else has a look at that form, and we'll do a reality check on it. So we've talked a lot about preparation. A lot of what I'm going to say now is reiterating the importance of careful preparation in advance. So we've said that oxygen is usually supplied by the airline. It must be booked in advance. Patients must plan ahead because there's likely to be a waiting list for the hypoxic challenge test. It's not available routinely in all hospitals. Airlines may charge. Many airlines now use the pulse dose system. Some very frail or small patients may not be able to trigger those systems. So if you think your patient might have difficulty, you should check that first at sea level. And we've talked about portable oxygen concentrators. They're very popular. They're light, battery-operated. But passengers must check that with the airline first. And obviously consider, as we've talked about, extra battery packs, not only for the flights and the stopovers, but as we've noted, the delays, which are quite frequent. So this is just an example of a medical form. We've talked a little bit about that. So usually the respiratory specialist will be asked to complete this. And again, patients must allow sufficient time for this. This comes on top of all the extra workload. It's got to be completed. The patient's notes have got to be checked. It's got to be returned to the patient. It's then got to be checked by the airline. So this is quite a time-consuming process. I've just given you a couple of examples here of a frequent traveller's medical card. So these allow patients and the airlines to record the details of what they need so that they don't have to fill in medical forms each time they travel. These forms are issued by a number of airlines, but they may be airline-specific, and they assume that the passenger's condition is stable. So the validity per period may differ between airlines. So we recommend that patients must get information before they travel. They must be reminded about the need to plan well in advance, to get formal agreement to take any equipment on board, to arrange medical insurance, as we've talked about. They should talk to their doctors about whether they need antibiotics or a supply of steroids before they travel. Think about reserving an aisle seat. And they should have a doctor's letter if they're travelling with numerous medications, unusual medications, trial medications, syringes, needles, or obviously metallic implants such as bronchial artery embolization coils. It's been said before, but we would reiterate, they need to take an adequate supply of their prescription medicines and their inhalers in their carry-on as well as their checked-in luggage. So you've got 2 supplies. You'll now need a doctor's letter for any liquid medicines that are over 100 mL, may be important for paediatric patients. We always advise passengers to stay well hydrated. Matthew's experience is very interesting, and to avoid or restrict sedatives because of the effect on your oxygen levels and alcohol. So lots of really good patient information sources are available now. We've touched on these. We've talked about the British Lung Foundation. The European Lung Foundation has done a fantastic amount of work in bringing together all the information in their airline index, which is a really wonderful resource. The BTS does have patient information in association with the recommendations. And then there are other specialist societies and charities that provide information for passengers with rather less well-known conditions. So just in summary, if there are no contraindications, this is an opportunity to optimise usual care, provide patient information and document advice. If patients do have risk factors such as previous problems during air travel, severe disease, recent exacerbations, or they already have requirements for oxygen or ventilator support at sea level, then they should be assessed, and you might want to consider hypoxic challenge test. If they're already on LTOT at sea level, less than 4 litres per minute, double the flow rate at cruising altitude, healthy newborn infants should wait for a week. Absolute contraindications, TB, pneumothorax, major hemoptysis, very high flow rates of oxygen at sea level. And this is the algorithm that is reproduced with permission from the Primary Care Respiratory Journal in 2013 that just summarises how to assess patients. So do they have any contraindications? No. If they're not in a high-risk group, then optimise their usual care. If they do have absolute contraindications, advise against. And then if they're in the middle group, are they receiving oxygen? No. Consider hypoxic challenge test and further assessment. So careful history, really important. There aren't many absolute contraindications. I would encourage people to advise patients the hypoxic challenge test is not a fit-to-fly test. Remember advanced planning. You can almost always travel by air if you have enough support, but the logistics or the economic costs may outweigh the benefits, and therefore the risk versus benefits needs review on a case-by-case basis, and complex patients should be assessed by a respiratory specialist and the advice carefully documented. Thank you.
Thank you very much, Robina. As time is pushing on, unless we have maybe 1 or 2 quick questions, I'd like to move on to Andy. We'll take these 2 questions over here. Man at the back first. Standing.
Thank you. Charles Simons from the Netherlands. I have a short question. What, in fact, is the risk of getting a pneumothorax in an emphysema patient?
Doesn't seem to be any really increased risk of pneumothorax from flying. The risk is if you've had a previous pneumothorax, and then the best treatment is definitive surgical pleurodesis, and then the risk is very low. If you've had a pneumothorax, the risk of recurrence is relatively high in the first 2 years, so that does need to be borne into account. I think the patients I would be concerned about are the patients with bullous disease. Big bulla, yeah.
Okay, thank you. This man here.
Just a quick question. I get quite a few referrals for hypoxic challenge tests in patients with tracheostomies in situ. What is your thought on patients with tracheostomies flying, having had a hypoxic challenge, which demonstrates they may or may not need oxygen?
Yeah. It's going to depend on the patient, isn't it, and how well they can look after themselves. I think, being very pragmatic, I would probably suggest, why don't you try a short one? See how you get on. I don't think the first flight should be UK to Singapore, but they may well be safe to travel. Yeah.
It's a quick question. Just one.
Thank you very much.
Thank you.